Good afternoon everybody and welcome. My name is Remco van Eenenaam and I'm a PhD student at the Rehabilitation Department at the UMC Utrecht. Today I would like to tell you something about communicating personalized prognosis that empowers patients to regain control over their future, on behalf of myself and my colleague Esther Kruidwagen. My PhD is in amyotrophic lateral sclerosis. For those who do not know, the ALS is a neurodegenerative terminal disease which leads to a loss of control of all voluntary muscles. It involves around approximately 1,500 people in the Netherlands. Their average life expectancy is between 3 to 5 years after first onset of symptoms. However, the life expectancy varies greatly between individuals. And in 2018, colleagues of ours, Westerling and others, they developed the NCAL survival prediction model. And with this model, it is possible to estimate the personalized prognosis of survival based on 8 characteristics. And here on the right, you can see the 5 survival groups, which each contain around 20% of patients. And as you can see, there is a great spread between these groups. I would like to talk to you today about assumptions. Should personalized prognosis be discussed with patients with ALS? If we look at research amongst physicians, we find that they prefer not to broach the topic. Why? Because they fear it could cause distress to the patient and cause a loss of hope in the patient. On the other hand, as researchers, we might conclude that you should discuss the topic, because studies show that most patients want to know and it may be beneficial to their satisfaction. It can help them plan for the future and provide a sense of control. However, then we forget the patient. Why do we not ask the patient? And this happens too often that we forget to involve the patient in our research. So what did we do? First, we decided to develop a communication guide. The goal of this guide was to support physicians to tailor discussion to the individual preferences of patients with ALS. On topics like, does the patient and the family want to know? What do they want to know? And how should they deal with the family, frontotemporal dementia, and the cultural background of patients? To develop this communication guide, we assembled a multidisciplinary work group consisting of researchers and physicians, and we also involved an expert advisory panel consisting of an ethicist, a spiritual counselor, and an independent physician, and most importantly for today, 2 patients with ALS and a family member. In the second phase, we wanted to study the patient and caregiver experiences with discussing personalized prognosis in ALS. To do this, we set up a qualitative study and we conducted semi-structured interviews with 13 patients with ALS and 10 caregivers. The themes resulting from these interviews are shown here. The first theme is tailored communication. Patients and caregivers told us that tailored communication mediates the emotional impact of their prognosis. Also important were personal factors like coping style and illness experiences on the emotional impact. Finally, patients told us that it helps to regain control. Concluding about assumptions in your research, I would like to give you that you should not assume what patients want, and do not assume to know what is best for patients. Do assume that patients are people and treat them as such, that patients are resilient. However, within your study you should not overburden them, of course, and patients can speak up for themselves, as a lot of healthcare professionals know, and you will notice if you speak to them during your study. The clinical message for the personalized prognosis is it has a minimal adverse emotional impact, it helps to regain control over the future, and can even facilitate planning of the future, including future care, and patients emphasize the quality of life over the quantity of time remaining. So when you go back to your own projects, I would like for you to consider involving patients in your study from the design phase to the implementation phase, to consider more exploratory, qualitative or mixed method studies, and just go and talk to the patients and the next of kin involved in your studies. Thank you very much.